Welcome everyone to the Cleft Palate Craniofacial Journal podcast, and it's both video and audio. I'm really glad that you joined us. I'm Pat Chibbaro. For many years, I was a pediatric nurse practitioner on the MyFace team for craniofacial care at NYU, and I'm really honored to be the podcast editor. And I'm always looking for really interesting papers and ones that I wonder, why did they look at this subject? And this is one, and I think everyone should definitely read this. And you can find this in OnlineFirst, and it was December 12th of 2024. And when you go on to the site, I can tell you that when you go to OnlineFirst and you scroll down, click on number 3, because then I think it brings that paper up. It's listed as a brief communication, but to me, it looks like more of an original article, full on paper, and it's really interesting. Recognizing variations in primary palatoplasty billing, a review of 9,827 cases. And this is a real team effort from the University of Mississippi Medical Center, Dr. Ashlie Elver, Wesley Zhang, Nancy Perry, Jamie Lewis, Laura Humphreys, and Ian Hoppy. And I'm really happy to have the first author, Dr. Ashlie Elver, who is a third-year plastic surgery resident there. So welcome, Ashlie. Thank you so much for joining me.
Yeah, you're welcome. Thanks for having me.
Yeah, and as I said, my first question, and I always ask this question, is why did you decide to do this paper? I think it was, as I read it, I thought, wow, this is really interesting and certainly important. And I think about my years of working with the surgeons and with the team, and billing was always, was often a challenge for the entire team.
Yeah.
So tell everyone why you decided to do this.
Yeah, so as a third-year plastic surgery resident here at Mississippi, we're lucky enough to be in the same proximity as the only children's hospital in the state. And so because of that, we have the 2 pediatric craniofacial surgeons here that we train with, and we see a lot of cleft palate care here. And of course, we're a designated center to provide that care. So I was talking with my mentor, who's the senior author on this paper, Dr. Hoppy, and he had mentioned that we had done a very complicated cleft palate, and sometimes in the very wide clefts, you really have to do extra maneuvers and techniques like a Vollmer flap, which makes the case not your standard cleft palate repair, not necessarily a slam dunk, and it can add a lot of time to the case and a lot of complexity. And so we were talking about the billing for that, of course, because that's, in the United States, and especially in this healthcare system, billing is a very big component that drives our, not only the care that, we provide, but also the equity of the system. And so he was talking about how it's crazy that he one time had tried to bill for this Vollmer flap, and our person who works as our primary biller in the administrative office had said, well, actually, the primary palatoplasty code is a bundled code, so you can't bill that code. And he had known that there were other people out there billing the code. And so we thought, we have access to this great database where we can see what CPT codes are being selected for this, one of the most common cases performed by pediatric craniofacial surgeons. So we thought, let's just see how many people are billing this code. And we were very surprised to find quite a few people, 6.8% of people who were doing a primary palatoplasty were billing this extra code, which is not something that we commonly do.
So interesting. So let me understand, and maybe let the the listeners understand. So you were just talking about bundled, unbundled. So maybe just talk a little bit about that. And the other thing I wanted to ask you is, and I'm trying to remember, as we do billing and coding, and I guess when the surgeon is sitting down with you and giving you codes, and then goes into the OR and then realizes they have to do that. It's an interesting issue, and what is it, what does it mean, and the
Yeah.
whole idea you're in the OR and then all of a sudden you realize you need to do something else. So so I have a bunch of questions. So, first, explain the whole issue, and specifically the codes for palate repair. It's really interesting. It's a little bit crazy.
Yeah. It's a really billing is a very complex topic, and it's something that I was unfamiliar with until I became a resident. And
Mhm.
even as a resident, our basically one of our duties is to log our cases, and we use CPT codes to do that. And so that was my first introduction to this whole CPT code thing. So at the very basic core of it is, what is a CPT code? So the AMA, American Medical Association, describes a CPT code, which is a 5-digit code, and it's assigned to each unique procedure. So in this case, we have 42200, which is a code that is supposed to be for the primary repair of the palate, the first time that a surgeon is repairing a cleft palate, recommended before the age of 1. Now, this is supposed to include all techniques to repair the hard and soft palate. But some in complex cases, in certain patients, the palate is very wide, and in this case that we are looking at, anterior, and you can potentially need a vomer flap, which is the lining of the vomer bone, to sort of come down and help you provide the nasal lining. Interestingly, that procedure in itself has its own CPT code, 42235. And so you would think that if you were not just doing your primary palatoplasty, but you're also doing a vomer flap, you would, to best describe your procedure, need to use both of those codes. However, as an initiative by the AMA and the Center for Medicare and Medicaid, they put out what's called these correct coding initiatives to sort of control healthcare spending, because each CPT code is associated with an RVU value, a relative value unit, which, long story short, gets translated into a monetary sum for reimbursement of the work that was done. And so they sort of put out these recommendations to decrease redundant codes, redundant spending, and make sure that we're not charging more and therefore increasing the overall debt of healthcare spending in the United States. So bundling is one of those initiatives. And it basically means that when there's one comprehensive code, that code should be used and no other codes. So in this case, since it says all techniques to repair the hard and soft palate, even when you are doing that extra technique, you should still use the same code. So that's sort of what bundling means in this case. And there is some controversy. I presented this paper in multiple places, and using the term bundling sort of implies that the surgeons here who use the two codes are doing something wrong. And that's not necessarily true. It just, because they don't specifically mention this combo as a unbundled pair. However, other coding recommendations that are used by professional coding societies do specifically mention that these two shouldn't be billed together. So if
Wow.
that, I know that it's very complex, but
It's
hopefully that.
almost like, as part of your residency, you need to have, take a full-on course in this, because, there's so many ins and outs with this. But it makes me think then that everybody needs to code at the highest possible code, and then go in and see what you end up doing. And, it just, I wonder then, what is the down effect on the families, where, and I think you may have
Right.
mentioned that in your paper, that are
Mhm.
there instances where, depending on how the coding is presented for billing, does the patient ever end up getting a bill because something isn't covered? That's, I guess, one of the things that I wonder about, and maybe you could talk
Yeah,
about that a little bit.
definitely. So that's always the motivation is how does this affect the care that we're giving and
Right.
delivering to these patients? Well, I think it's twofold. The first problem is sort of indirect, but if you work in the United States, it's sort of a um value it's not a values-based system at the moment. It's sort of an RVU driven system. Productivity is measured by the RVUs you deliver to your hospital system. And so when a very complex surgery is undervalued, it has implications for how the surgeon is valued in the hospital system, and how that surgery and how they spend their time is valued by the hospital, which translates into OR time, into access, and basically equitable care for patients. So that's why, for me, I'm very passionate about making sure that this important work isn't undervalued so that these patients don't go underrecognized and their resources don't go undervalued, because the last thing we want is there to be a waiting line for a cleft palate repair because
Sure.
the hospital doesn't value that time. And then the second question, or the second problem with this, is the theoretical issue with insurance companies. And if they see that you sort of double coded for a bundled code and they don't think that you appropriately billed, they can deny that claim for that extra
Oh,
code.
oh, for the extra code. Okay.
Now, at our hospital, that the way that our billing system is, the patient doesn't end up with that bill for the extra code. We would sort of have to go back to our operative note and make the appropriate edits and make sure that we bill the patient the code that the insurance company is going to bill, or that is going to pay for. But theoretically, there is a concern that an insurance company could deny this claim and the patient could be left with a bill and the hospital could not write it off and it could be sent to the patient. So that was one interesting scenario that we had sort of tried to bring to light. If we don't all get on the same page about this, then there could be some serious, and maybe there has been, and hopefully this will generate discussion from others and we can sort of find out if there are actual problems in individuals affected by this.
Right, right. So I think you mentioned earlier, the things that you were surprised about. Maybe we can go through a little bit about your process and what you found.
hmm Yeah, so I think the first surprising thing was how many people were billing these two codes together, just based on our institutional recommendation to not bill this code together. So that was the first surprise. Um, Really, when comparing the groups, we did sort of basic statistics just to see if there were any differences in perioperative variables. One notable finding is the operative time. So the operative time was longer in the group who had two codes, which sort of tracks with the fact that there was an extra technique performed and the surgeon took extra time and had to have that, high technical skill to perform that repair. So that was interesting because it really backs the surgeon up that who did bill two codes. They did some extra work there. Um, so that was an interesting finding. And then the other two things, after we had written the paper and we had submitted the abstract to a couple of meetings, there were some surprising comments that I got along the way. Some surgeons were like, oh, of course, you should always bill this when you're doing a vomer flap. And at the same time, because I was presenting this as a poster where many people were allowed to walk up, and we
Right.
kind of had like a group discussion, and another surgeon was like, are you serious? I've never done that before. So it sort of just revealed the variation and approach to billing for this procedure. And then the second surprise was a question I got on a podium presentation where a surgeon had said, well, 6.8% seems a little low. There's probably many more surgeons performing a vomer flap that are just not billing for that. And that would have been our case. So that sort of brought to light, you know what, you're right. We should have a better idea of how many people are actually doing this and not, putting this extra code or being quote unquote compensated for the work that one of their peers performed the exact same procedure and is compensated double the RVU value. So those
Exactly.
were some of the surprising things along the way.
So interesting. Wow. So, I'm just going to look at your paper for a second because I wanted to read something that you wrote in the discussion or maybe in the conclusion. Let's see. At the very end, you wrote efforts towards fair and clear compensation in craniofacial surgery is needed from governing bodies. And I read that and I thought, whoa, I think you could devote the rest of your professional life to working on this. But I wonder, you're a resident, you're embarking on this journey, and what thoughts do you have? And I maybe, I'm talking to other of your colleagues who are residents, I mean, this is your future, how and it can be very time consuming. I remember, just sitting with billers and back and forth, and then you get the denials and then it's back and forth.
Mm-hmm.
I wonder, do you have thoughts, about this and what you think should be done, in terms of making changes with this?
Yeah. So I think I have found a very interesting niche in the billing world because I think craniofacial, and there's a couple of papers out there that have shown this, that the codes are inaccurate. They don't describe the procedures at all. For instance, for mandibular distraction, we're using orthopedic codes and osteotomy codes, and they're not specific. And then this leads to a problem of undervaluation, which has also been shown in the literature. And I think that becomes a real problem because our specialty as a whole becomes undervalued, and the services we provide and spend 7-8 years in training, just in surgical training, plus over 10 years in medical training. And it's hard because you have these governing bodies we're such a small population of surgeons, so they're not really paying attention to us too much. And I think that finding this database and being able to easily look at CPT codes for common procedures has been an easy way to sort of publish these papers and show, look how variable this billing is, look how across the board things are, and getting more attention to things is the very first step. So I've been working on reproducing a similar type of study with a couple of other craniofacial procedures. And then the next step, I think, is talking to other craniofacial surgeons. And meetings has really allowed us to do that, and surveys. So we've got a couple of survey studies that we're doing right now just to see, hey, what's everyone billing for this common procedure? And we've actually found that it's not the same.
Oh, I'm
Pretty
sure
much
it's all
everyone's
over the
doing something
map,
different.
and I think that's the great thing about, having an organization like we have with the American Cleft Palate
Yes.
Association, is using this organization to try to make these kinds of changes because you need the numbers. And, I was thinking, I wonder, it'd be interesting to think about having some kind of a task force even of surgeons and to really, to try to, as you said, it's interesting because I was, I've been around a long time, was there for the first mandibular distraction before you were born, probably. And still, all these years later, the code for it is not really accurate, and I think, it would just make sense that, we would, and you as the surgeons would be able to come up with a very correct, accurate list of what the coding should be for these, we are this small specialty. There should be a very specific group of craniofacial procedures that are not other people's procedures, that are yours, that are very specific.
Yeah, I agree with that. And it's not like these surgeries are uncommon. We're doing the same surgeries every week. We're doing a mandible distraction, at least a couple times a month. And it's so important for this patient population. But I definitely agree. And that is one of our initiatives and our goals, is to get enough attention toward this topic that we can get a task force. And we were actually just talking about this week, because we're trying to do a new survey of craniofacial surgeons, and we were like, we got to get this out before the ACPA meeting, because we're hoping to, if we didn't get enough survey responses online, we wanted to sort of get a paper survey and try to get more attention toward this topic. But
listen, that
was where we got a lot of.
No, that's a really good thing to do, is bring it, that this is your captive audience, and, and that's a time where they might have a few minutes to fill out a survey of yours and get the most data possible. No, I think that's a great idea, is to really capitalize on having this group together. So, no, I think it's, it's just amazing that 30 plus years later, I'm still hearing the same, concerns and issues and challenges. And, we just, you don't want to, it's just it's a waste of energy and time. Plus, as you said, is to make sure that it's valued, that the work is valued, that it's equitable. All those things that you said are so important. I'm really glad to see you doing it. Before we wind up, is there anything else that you might want to mention about your work? Or also, I always like to ask, do you have any advice for some of your early, your colleagues in plastic surgery residency who are looking to do some studies?
Yeah, I would just say my advice is always find a mentor that you share similar passions with when they have a problem and they're just candidly talking about it, and you also get angry or passionate about that problem. There's probably something there. And do what you're good at. I've always been interested in databases, and so I knew that this would be a perfect project for me. And because of those two things, a mentor and doing things that I like to do, it's just been easy to, go down this line and get passionate about craniofacial care and making sure that these services are valued. And I see a future in sort of actually making a difference. Whereas some research projects, you do it and you describe it and then you move on. But this is sort of one of the things that I've done that I feel like there's actually something to do here. And I'm excited about going to ACPA this year and getting other people fired up about it. And hopefully, maybe, like you said, getting a task force together. That would be awesome.
Well, when I see you at the meeting, I know so many craniofacial surgeons from all my years of training them at NYU. So I will be happy to help you get them to fill out those surveys for you.
Yes, I would love that. That would be awesome.
Absolutely. So let me just, for the listeners, just let you know again that we're talking about the paper that you can see in OnlineFirst, and it's from December 12th of 2024. Recognizing Variations in Primary Palatoplasty Billing, a review of 9,827 cases. The authors are from the University of Mississippi Medical Center, both the Division of Plastic Surgery, the School of Medicine, and the Department of Surgery Administration and Finance. Very important. I want to make sure I mentioned that it was a real team effort. And the authors, Dr. Ashlie Elver, Wesley Zhang, Nancy Perry, Jamie Lewis, Laura Humphreys, and Ian Hoppy. And I'm so happy to have had the first author, Dr. Ashlie Elver, with me. I'm really excited for your future. I think you're already making an impact, and you're gonna make a big difference, and good for you. And I look forward to seeing you at the meeting in Palm Springs. Yay.
Yes. Thank you so much for having me.
All righty, great. Thank